So I would say right now the current standard of care is RVD, which is lenalidomide, bortezomib, and dexamethasone. There's ongoing studies asking the question whether we can improve upon that by adding a second-generation proteasome inhibitor, carfilzomib, instead of the bortezomib. But we know that especially for patients with high-risk disease, even though they initially do well, they have a much higher rate of relapse and shorter progression-free times. And so really the question is going to be, can we do something that will significantly change the outcomes for high-risk patients? So I think there's a lot of excitement about KRD, which is the carfilzomib, lenalidomide, dexamethasone. There's also some interest, particularly in the older patient population, in lenalidomide, ixazomib, dexamethasone, which would be an all-oral regimen and which might be well tolerated. We're eagerly awaiting the results of a phase 3 study that's finished accruing, which compared lenalidomide, dexamethasone to the triplet lenalidomide, ixazomib, dexamethasone to see whether that in fact improves survival outcomes. With respect to the quadruplets, I think the most interest so far is with adding antibodies such as daratumumab to the PI-IMiD backbone. So daratumumab RVD, daratumumab KRD. Initial studies are showing very high response rates, but really we are going to need the larger studies to really see if we're making significant changes in overall survival.